Great. So thank you again for the opportunity to present. I'll be discussing this paper on the behalf of a multidisciplinary group of vascular providers, co-led with Dr. Neil Butala sitting in the back table here. These are my disclosures, none relevant to this presentation. So in the CABG versus PCI space where we all live, we have at least 23 randomized trials of over 13,000 patients to evaluate the right strategies in terms of when to refer for a bypass surgery versus a coronary intervention. In the peripheral vascular space, we had one until recently. Now we have three, and I'll be discussing one of the more recent trials, totaling 2,600 patients, to understand strategies for a very complex disease, where we know that patients have different risks, and also the actual anatomy differs based on the condition and presentation. In BEST-CLI, and I won't go into the exquisite details displayed here, but I do want to just document that this was a randomized trial funded by the NIH looking at a strategy in the main cohort, cohort 1, of a vein graft versus an endovascular intervention for infrainguinal disease, totaled 1,400 patients, and they looked at a composite outcome of major intervention and amputation-free survival. And they found that at 2.7 years of median follow-up, the primary outcome was driven by a reduction in major intervention with some less a prominent reduction in amputation and similar survival. So this was really seen as a favorable result for surgery, but there was a lot of questions that came out of this trial, especially for us endovascular operators. Many of us who were not participants, as about 85% of this trial were vascular surgeons and 75% did the endovascular work. So our goal here was really to generalize these results into a more average clinical practice that we run into daily in our hospitals, to understand how specialties work together in terms of this field, and really to see how these outcomes reflect what we are observing again in our routine practice in a well-documented Medicare population. So for this trial, we really tried to replicate the study period and some characteristics of the BEST-CLI trial. We were able to capture many of the inclusion and exclusion criteria, minus some of the anatomical considerations and the equipoise between a surgical or endovascular treatment. We're able to capture if a patient underwent a venous versus a synthetic graft conduit, and also capture the primary endpoint that was seen in BEST-CLI, which was a combination of amputation, major intervention, and death. For this, we really want to answer several questions. So the first was, just from a bird's eye view, do our outcome rates look similar to what we're seeing in the BEST-CLI population? We then wanted to see whether we can really replicate the trial within the Medicare population through a trial emulation design. And then I had some kind of questions that I was looking at is, for this study that took over 10 years to enroll, how generalizable are these results to our CLI practice? Because we know that most sites enrolled only about 10 patients over the study period. And so we looked at the actual sites and how many patients were treated there during the study period, the type of physicians who were practicing at these sites, and also how the outcomes differed if you were treated at a trial site versus a non-trial site. So this is the table 1 baseline characteristics of our population. In column 1 here, you can see cohort 1, which is the main venous bypass cohort of BEST-CLI, 1,434 patients, and then our cohort of Medicare patients of totaling 58,000 after those inclusion and exclusion criteria. And as expected, our population in Medicare, which is about 80% of the CLTI community, is older, sicker, but interestingly also a little bit more diverse. And so although primarily Caucasian ethnicity, we saw more females being treated in the Medicare cohort. And I think, again, these really reflect what we're running into on a daily practice. I will note that although BEST-CLI had a more broad age enrollment criteria, the average age was still very close to what we observe in Medicare, which is right around 70 years. When you look at who treated these physicians, and BEST-CLI on the left here, you can see this chart looking at vascular surgeons, which was 73% in the endovascular treatment for the cohort 1, 14% cardiologists, and 13% radiologists. And you can see in the community of Medicare operators practicing in the U.S. that about 55% are done by vascular surgery, and the rest is really a mix of endovascular specialists, whether interventional radiologists or interventional cardiologists. So a little bit less representative in the BEST-CLI trial as is done in routine practice. Just comparing without adjustment outcomes seen between the cohort 1 of BEST-CLI and that in Medicare, we found a couple interesting parts to this. First off, we were able to really match the same endovascular outcomes seen in BEST-CLI as observed in routine clinical practice. And so this is on the left for major adverse limb events or death, However, we didn't see the same outcomes for surgical bypass, which is to be expected. Again, Medicare being a more comorbid population, a little bit older. We also saw in BEST-CLI that there was a very high rate of major intervention, and we will really go into this in a moment, but there was early crossover from a failed endovascular procedure to what was a major intervention, which was surgical treatment. And that's really not observed as much in clinical practice, where very often we use stepwise endovascular approaches to treat these patients. We do one, it may need another procedure, we may bring them back for another, and that's part of the treatment strategy that we would typically undertake. Minor interventions, however, which is balloons or stents, were pretty equivalent to what was observed in BEST-CLI. So how do outcomes look? Now, this is, again, confounded by the fact that it's not randomized data. This is adjusted, and again, we tried to emulate what would happen if we did this trial in real-world evidence. But we did see, again, that there was a slight signal that patients in Medicare who undergo bypass surgery do have a slightly higher risk of an adverse event, primarily driven by increased death. And we've observed this also in a recent trial called BASIL-2, which was a randomized trial done out of the UK. So we know that surgical treatment for older patients, as we would expect for any type of surgical intervention, tends to have worse outcomes, and particularly peri-procedurally, some of which we observed here. In terms of outcomes for amputation, we did also see a slightly lower risk in the endovascular group than in the surgical group, which was a little bit surprising because we thought we'd be confounded the other way, that a healthier population would go to surgery and have better long-term outcomes. So this was a little bit more of a surprise for our study. When you're thinking about who was enrolled in this trial, there was no evidence in the BEST-CLI trial of how many patients were screened before they were randomized. So we really only got the top-line view of how many people made it into the trial and were randomized and treated, and the only people who fell out were those who crossed over or didn't make it onto the procedural table. When we actually pulled all the top enrolling sites, you can see here in blue bars, these are the number of Medicare patients were treated at these sites during the study period, and in red, how many of these same sites enrolled in BEST-CLI. And just as a generalizability question, we note that there was a lot of patients that were being treated in the community that didn't make it into this trial, as to be expected. But this is really important for the community when you're applying a trial result to a population that is varied and with different expertise at each of these centers. Lastly, if you were treated at a trial site, you happen to have better outcomes than if you're treated at a non-trial site. So there were specific operators who were enrolling in that trial that did have better outcomes, particularly on the surgical side. And we know that can be a combination of many things, whether institutionally they have more resources, better follow-up, and maybe better tools to deal with these patients. There are many limitations to this analysis. This is not meant to replicate or overcome all the results that were in BEST-CLI. BEST-CLI is an important trial, and we know that venous bypass is an important part of our practice. We lacked many of the characteristics needed to fully replicate and emulate what that trial would look like. And again, I think that it's important to note that major intervention in this study didn't take into account technical failure, which was a primary driver of failure in the BEST-CLI trial. So in conclusion, I think it's very important to note that BEST-CLI enrolled a specific population of patients with lower surgical risk and equipoise between revascularization procedures. And for the enrolled population, the BEST-CLI trial provides robust evidence that surgical venous bypass for candidates with CLTI is an important strategy. I think our study does suggest that not all patients fit BEST-CLI criteria, and I think we all know this, and that it's hard to apply that full finding of that trial into our general practice on a daily basis when we're caring for a sicker population. And I really think this is important for contextualizing how we move forward with implementing these results into clinical practice. Thank you very much, and these are now live on SCAI as well. This QR code will take you to the paper.
It's a great presentation. I think if you're Medicare and you're a large insurance carrier and you want to do value-based payments, I think it's really important to have that data. So what do you think Medicare would say as a payer when they saw this data?
Yeah, I mean, it's a really important question. You know, there were the BEST-CLI results again were really important. The one thing that I didn't talk about is that 1 year quality of life was similar between groups, even though there was a strong favorable outcome in favor of surgery. And so if you're looking at this from a Medicare standpoint, you're thinking about the patient, you're thinking about the cost and the time in the hospital. And if we're ending up at the same point or even better off with endovascular, you have to think about that when you're deciding whether you're going to start shunting all these people to surgical evaluations, longer lengths of stay. And we know that about 30 to 40% of CLTI patients die at 1 to 2 years. So
yeah, that's super important to know. So just straight to the panel. Any questions?
Yeah, thank you for a very nice presentation on BEST-CLI data. As you were discussing your data, I was reminded of the CREST randomized trial for carotid stenosis that had a proficiency requirement for all the endovascular operators to do a certain number of carotid stents during a certain period to bring the results up to par, because there's a lot of heterogeneity in carotid stenting. Could you comment on the proficiency requirements for endovascular care in
Yeah, I think that's something in our endovascular community that we were a little bit disappointed in, because it was, I'm going to blank on the exact number, but it was in like the 5 to 10 range of endovascular procedures required prior to participating as an endovascular operator. And again, we're all coming from this with different skill sets, and it would have been nice to see a little bit more reflection of the endovascular operators outside of the surgical specialties in this. Tonight we'll have a session on BASIL-2, which is a partner trial done in the UK that just came out. And if you look in that trial, which showed a different result, which favored endo, 84% of the procedures were performed by interventional radiologists. And I don't think that is necessary. There's fantastic surgical endovascular specialists out there, but it does give some complementary data about what is the proficiency in the endovascular space needed to be a good operator.